So what we've heard so far is that climate change is real, it's happening, it's caused almost certainly by people, it's causing terrible human health and natural effects, and emergency medicine is clearly the specialty to tackle it. And that's great. But we're missing one key piece here. It's that we in healthcare have this dual role, that we are well trusted and we can be part of the solution, but we're also the problem. We are a huge part of the problem, in fact. So let's cover the happy part first, that we're well trusted. So this is a poll run by Gallup just this past December, early December 2017. The question was, how would you rate the honesty and ethical standards of people in these different fields? And the choices were very high, high, average, low, or very low. So not surprisingly, the profession that's always at the top of the list is nurses. In every year that Gallup has done this poll, nurses have been at the top of the list except for once. In 2001. They included firefighters on the list, and they ended up #1 over the nurses. But otherwise, nurses are always #1. But not too far down are doctors and pharmacists. So of the top 5 professions, as far as being ranked the most ethical and trustworthy, 3 are healthcare. So we're trusted. People believe us when we talk to them. We can be part of the solution. But here we're also the problem. This is a chart of energy intensity per square foot for a variety of different kinds of buildings in the United States. You might not be able to read it, so let's see if you can't read it. What do you think is the most energy intensive industry in the United States? Nobody wants to guess? Nobody? It's not healthcare. Nope. It's food service, because they have to cook a lot of food. But #2 are hospitals, and #4 are non-hospital healthcare settings. We're open 24 hours a day, 7 days a week, 365 days a year. We have heating, we have air conditioning, we have lighting, we have impressive HVAC systems for our ORs to turn over the air 3 bajillion times an hour. It takes a lot of energy to do those things. We are the problem, or at least a part of it. Here are greenhouse gas emissions by country in 2013. There are a lot of very small countries in that other category. Trust me, they're just really small. China is by far the largest emitter, but the United States, we're trying to be the best. Where on this chart do you think healthcare in the United States would fit? If the United States healthcare industry were its own country, where would we fit? Okay, so I hear Russia, I hear Germany, Japan. Those are pretty good. Any other? Canada. There's Canada. So the U.S. healthcare is right there. It would go in between South Korea and Australia. That's more than the entire United Kingdom. Like, that's a pretty populous, Western, industrialized country. The United States healthcare sector is big. It emits more greenhouse gases than that. And then with our emissions, I'm going to transition a little bit. I know we're talking a lot about climate change and greenhouse gases, but there are other environmental ill effects of healthcare, and we hurt people with them from the healthcare industry. This is the result of an economic input-output life cycle assessment of the United States healthcare industry. And on the far right, you see the DALY's loss. DALY's, if you don't know, disability adjusted life years. It's essentially a measure of how much you kill people or make them disabled from some effect. It's a typical economic measure for comparing perhaps the cost effectiveness of various treatments. So here we see that in 1 year, the U.S. healthcare system, from its environmental pollution, This is not from medical errors. This is not from adverse drug effects or surgical site infections or anything like that. This is just from the pollution that we generate by treating people. We caused about 470,000 disability-adjusted life years lost. To put that in perspective, that's about the same order of magnitude as what the Institute of Medicine says is the result of medical errors. When To Err Is Human came out, the report from the Institute of Medicine many years ago, there was a huge uproar. It was in the press. Hospitals had to do things about it to try and reduce the medical errors that were killing people. Well, our pollution is about the same amount. We need to clean our own house before we start telling other people to clean theirs. It's what I describe as a non-virtuous cycle, that people, for whatever reason, have poor health. Something happens. So they seek healthcare services, as they should do, so that we can help them. That's what we're here to do. Our healthcare services, unfortunately, generate environmental degradation and climate change, which, as you just heard from everybody who spoke before me, leads to worsening health. And then we start all over again. Somewhere in here, we need to break the cycle. For many, many years, healthcare was given a pass when it came to costs of care. We could spend whatever money we needed to in the name of making people healthier and saving lives. That's no longer the case. We healthcare providers are under a microscope to control our costs, to reduce the impact that we're having on our national and world economy. Healthcare represents about 18% now of the United States economy and generates about 10% of the United States greenhouse gases. So we are under a microscope for costs. It's time for us to give up that pass on environmental degradation. Up until now, the SAEM healthcare service has always trumped environmental degradation. But we need to think about that. We need to think that, wait, the healthcare I'm providing, the services I'm providing are also hurting people. And we need to balance them. So we need a way to balance them. I'm here to tell you how to balance them. Someday, perhaps you will all balance them with me. I use a tool called Lifecycle assessment. It's a holistic method of assessing a product or a process from cradle to grave. We look at everything, upstream, downstream, left, and right. The idea is that we need to look at our product or our process, in this case providing healthcare, the same way that we look at a patient. Emergency physicians are the few remaining doctors who actually look at a whole patient as opposed to just the left pinky toe. I assure you, I can find that specialist at the Massachusetts General Hospital. We are not that specialist. We look at the whole patient, and we need to look at our environmental impacts in the same way. We do this with established methods. There are actually 2 international protocols, ISO standards for life cycle assessment, that outline what is included, how to do the study, and make it so that they're comparable and able to be reviewed by anybody else doing it. We look at everything from raw material acquisition, extraction from the ground, transport, manufacture, refining, use, reuse, reprocessing, and ultimately disposal. It's a comparative tool. It's kind of challenging to do it just looking at one thing. So the idea is you want to look at choices. Perhaps the most famous life cycle assessment choice was diapers. It was done in 1994 by my former company, Arthur D. Little. Procter & Gamble was making disposable diapers at the time. Before the kind of early 90s, disposable diapers were not so popular, mostly because they didn't work very well. But then they started working better, and there was a big question over whether they would be worthwhile in the marketplace, and could there be an environmental claim to be made about them. So Procter & Gamble hired Arthur D. Little, at the time one of the world's oldest consulting companies, to study it, and they did. They released around a 50-page report in the end of 1994, and it said that, well, the answer depends. There's no easy answer. Because when you're doing a life cycle assessment, you're looking at multiple impact categories. It's not just climate change potential greenhouse gases. It's not just smog. It's not just human health cancer effects. It's everything. And what they found was basically if you lived in a water-constrained environment, you're probably better off using the disposable diaper because it takes a boatload of water to wash reusable diapers. But if you live in a land-constrained environment, right now I want you to think of Arizona versus Massachusetts, then the reusable diapers are probably better because you don't have to throw them out. You don't need to truck them off to a landfill that could be hundreds or perhaps even thousands of miles away, depending on where you live. We can do the same thing with healthcare. This is the output from a life cycle assessment of this was delivery, birth, labor and delivery of a child. And the comparison that they used was vaginal delivery versus a C-section. Here are the standard life cycle impact categories that are typically used in our studies. Global warming is the first one listed. Then you have acidification, smog formation, respiratory effects, ozone depletion, lake eutrophication, carcinogenics, so human health cancer effects, non-carcinogenics, that's human health non-cancer effects, and ecotoxicity. To try and look at everything. Rarely do you see a life cycle impact assessment where one thing is always worse than the other. Which one is worse?
A lot less remunerative if you don't have OBs
I don't. But from an environmental perspective, the C-section is worse in all of the categories. Non-carcinogenic human health impacts, they're a little closer. The convention is that we scale to 100% for the worst one, and then you can see how much better the other one would be. We can use this tool to look at either midpoint effects or endpoint effects. We generally like to use midpoint effects because it's really hard to convert to endpoint effects without giant error bars. So that's why if you look carefully, these units are things like kilograms of CO2 equivalent, or kilogram of toluene equivalent, or kilogram of nitrogen equivalents. You can then take it another step and model it to say, how many more asthma exacerbations is this going to be? How much is that going to cost? And we can make those comparisons and make very strong arguments to the people in charge. Now I'm going to appeal to this base instinct of emergency medicine here. We are not the best people around. Are you going to let the anesthesiologists do better than you? Because they are. Eco-efficiency of disposable and reusable surgical instruments, scissors. These were all done by anesthesiologists. Life cycle assessment and costing methods for reusable and single-use disposable laryngoscopes. Greenhouse gas emissions of anesthetic drugs. Reusable and single-use central venous catheter kits. A financial environmental cost of reusable and single-use plastic anesthetic drug trays. This one's in German. It's single-use versus reusable surgical drapes. Life cycle assessment of disposable and reusable LMAs. There's a whole greening the OR checklist. We have none of this in emergency medicine. Yet. I think that it's time that as Renee and everyone else has explained, this is our topic. This is something that we are uniquely poised to tackle. So it's time for us to show that we are up to the task, that we can be every bit as environmentally conscious as every other specialty in medicine, if not more so. I had an attending physician when I was in medical school, an internist, who said to me, you know, I probably should have done emergency medicine all my friends in emergency medicine, they go kayaking, and they go mountain climbing, and they go biking, and I go to work. We do these things because we like them. This is our opportunity to protect them. So what's next? We can tackle these things, and there are a number of topics that are important. We can tackle waste management, hazardous waste, non-hazardous waste, biohazardous waste. How can we do it better? Food. What is the impact of the brown paper bag turkey sandwich that we give everybody? Can we do better by sourcing our food better within our hospital? Toxic chemicals. These are little beads of mercury that thankfully are virtually unheard of in American hospitals. But they used to be. And there are other toxins, like what I call the baby killer wipes that we use to clean every surface in the hospital that have the sticker right on top with the little knot sign with the baby in it. There's a reason you're not supposed to use them on babies. Our energy efficiency. Our transportation, and I'm not just talking about transporting our patients, I'm talking about trying to come up with ways to quantify and nudge our employees to improve the methods we use for transportation. I was on a flight this morning with, let's say, 8 physicians from Boston, all coming to the exact same place. We took 3 cars. That's not terribly efficient. So we can do better, we can work together, we can use the tools that are available to it. Thank you.